Okay, great. So welcome everyone to this HIV Prevention England webinar on sexual health and HIV in older adults. We're joined today by three fantastic speakers, Dr Gemma Spiers, who's a Senior Research Associate in Older People and Frailty Policy Research Unit within the Population Health Sciences at Newcastle University. And Gemma is going to be presenting findings from two rapid reviews about older people's sexual health. Then we'll hear from Professor Kaye Welling, who is the Professor of Sexual and Reproductive Health Research at the London School of Hygiene and Tropical Medicine. Kaye is presenting evidence from stakeholder consultations on sexual health among older adults. And then last but certainly not least, we'll hear from Alex Sparrowhawk, who is the HIV and Ageing Manager at Terrence Higgins Trust. He'll be talking about the latest HIV data and the current and future work that Terrence Higgins Trust is doing to identify and meet the needs of people aging with HIV. We will have some time for questions halfway through the webinar and at the end, so please do use the Q&A function to ask any questions as we go throughout the webinar, and we'll come to those during a break. So without any further ado, I'll hand over to Gemma. Thank you very much.
Thanks, Nicola. I'm just going to share my screen. So can everyone see this? Good. Okay. Hi, everyone. Well, I'm going to tell you about a piece of work that Kaye and I were involved in. It was a collaborative piece of work between the Older People and Frailty Policy Research Unit and the Public Health Policy Research Unit. So I'm going to talk first about the reviews component, and then Kaye is going to come in and talk about her work with the stakeholder consultations. Before I start, I do want to credit Melanie Stowell, who was the primary researcher on this project, and she was the person who really drove forward this work and pulled together a lot of the evidence that I'm going to present today. Unfortunately, Melanie now lives in New Zealand, and because of the time difference, she can't be at this webinar, but I do want to credit her. A lot of this work is down to her. So, for this piece of work, we wanted to know what existing evidence could tell us about the sexual health needs of older people and what might work to address these needs. So this is quite a sizable evidence base. There's a lot that's been published around older people's sexual health needs, and a lot of it has already been synthesised in existing systematic reviews. So to collate and understand this evidence, we used a method called umbrella reviews, and this is a way of systematically identifying relevant literature in published systematic reviews and translating this evidence in a way that answers our question. So we had two questions. One was about needs and one was about interventions. So we conducted two umbrella reviews. And because this was a policy responsive piece of work, we streamlined the method using rapid methods. I'm not going to go into detail on all the methods, but if you would like more information, please get in touch with me afterwards. I'd be happy to provide any information that you need or share the report. So let's look at the findings from the first review about older people's sexual health needs, where we synthesised evidence from 15 systematic reviews. And this evidence included the perspectives of older people, as well as the perspectives of health professionals that support the health of older people. So first and foremost, an important finding that came from this evidence is about how older people define and view sex. So sexuality can be an important part of healthy ageing, but there was a view that social norms of penetrative sex can be unhelpful and off-putting, and some older groups prefer a definition of sex that includes alternative forms of sexual expression and physical intimacy. And I think this is important and has implications for the way that health practitioners respond to the needs of older people. And whilst sex can be an important part of healthy ageing to some people, age-related factors can hinder older people's sexual health and well-being. So these age-related factors include things like the impact of long-term health conditions, or spousal caring, or losing a partner, or moving into and living in a care home. So when we looked at the evidence about older people's sexual health needs and the needs of health practitioners, we saw some interesting tensions. I'll just go through these. So the first tension was around whose responsibility it is to raise problems relating to sexual health. So there's evidence that some older people wanted professionals to be proactive in initiating these discussions to make it easier for them to discuss their needs and to do so in an environment that fostered that open and safe discussion. But at the same time, we saw evidence from health practitioners that they were reluctant to initiate these conversations and that they assumed that older people would raise any concerns around sexual health if they had any. The second tension was around stereotypes, stigma, and discrimination. So older people felt that societal assumptions of asexuality in later life undermined their confidence to discuss and have discussions with healthcare practitioners. And there was a fear that sexual health problems might be dismissed as a normal part of aging, especially if those sexual health problems are linked to an existing long-term health condition. But at the same time, health practitioners didn't always have a confident understanding or recognition of later life sexuality, and nor did they feel confident in understanding how to support older people's sexual health. The third tension was around sexual health for residents in care homes, where older residents were concerned about a lack of privacy and sexual activity being prohibited. But at the same time, there was evidence from care home staff that their primary concerns were around the safety of residents and colleagues. And they also raised questions about whether they had a role in moderating or even preventing sexual activity amongst older residents. So these are some interesting tensions around the needs of different groups, and they do have implications for moving forward with policy and practice in this space, and it might be interesting to discuss that later. I'm going to move on to the second umbrella review now, which looked at evidence around interventions to support older people's sexual health, and we reviewed evidence from 12 systematic reviews. So in this matrix here, we can see the sorts of interventions and outcomes that are reported in the systematic review literature. So there isn't a huge range of interventions and outcomes that are currently contained in published systematic reviews. We typically found interventions, educational interventions that were targeting older people with HIV or targeting the training and knowledge of health staff that were supporting older people with HIV. And then we also found a chunk of evidence around interventions to improve sexual health outcomes linked to menopause symptoms. So these interventions included vaginal estrogen, aromatherapy, exercise, and laser therapy. So the cells that are shaded in green are where systematic reviews concluded that there was evidence that an intervention improved a particular outcome, and cells that are shaded orange are where there was inconclusive evidence from review. The number of paper icons indicates the number of reviews that we found about particular intervention and outcome. And the icons that are shaded red are where we judged those reviews to have some risk of bias. So you might look at this matrix and think, okay, there's some evidence that some of these interventions are effective in improving some outcomes. However, I do think we need to interpret this evidence with a lot of caution. So as I say, some of the reviews were subject to bias. Some of the reviews didn't contain many studies, and most of the reviews didn't report evidence about the long-term sustainability of any observed benefits. But most critically, most of the reviews that we included in this umbrella review, they raised concerns about the quality of the primary evidence that they were reviewing. So I think it's really important to take this evidence here with a healthy dose of skepticism. So our key takeaways from these reviews are that for older people who are sexually active and for whom sex is an important part of healthy aging, there is a clear need for tailored, proactive support from healthcare, especially when age-related factors might impact on sexual health and well-being. Equally, what we're seeing is that health practitioners want a bit more training and a bit more education about how to support older people's sexual health. we are limited in what we can say and conclude from evidence about what works to support older people's sexual health, and that's because of the challenges and limitations of that data and that evidence. But I think Kaye is going to unpack some of the thinking around potential approaches to supporting older people's health based on her consultation work. So it'll be interesting to hear what Kaye says. If you would like more information, we do have an integrated summary of the findings, and it'll be at this link, and I'll pop that in the chat too. But if you'd like to discuss this at all, or if you'd like more information, please do get in touch with me at this email. Thank you. I'll leave it there.
Thanks very much, Gemma. We've had a couple of questions come in, but I think what we'll do now is hand over to Kaye to present, and then we'll come back to the questions halfway through the webinar, if that's okay. So Professor Kaye Welling, if I can hand over to you. Are you happy to share your screen? You've got yourself muted, Kaye.
Okay, I'm so sorry, then you'll have missed my introduction, which was to say good afternoon, everyone, and that we were a separate team, but obviously connected in terms of the aims of the project. Narissa and Maria are in the audience, so I'm sure they're going to add any comments later. So if I can just start from the first slide. We were charged with conducting a stakeholder interview of both key experts in the field, both in geriatric health and in sexual health, and older adults themselves. And to do that, we gathered 11 stakeholders in person in a focus group, 10 online in another focus group, and we conducted 4 personal interviews, and we had input from 7 older adults who had health conditions affecting their sexual health. We used data, we used information from the reviews to trigger discussion, and we added data from NatSal because that hadn't featured in any of the reviews. And the first thing that was raised was that in using the term older adults, we should definitely not be thinking in terms of a homogeneous group. The age group 55 plus contains men and women with quite different characteristics in terms of demographic, health status, and sexual health, sexual activity, as you'll see. If you look at the table at the bottom, you'll see that there are distinct differences. The 55 to 64-year age range, women are twice as likely to be sexually active in the last month as those aged 65 to 74. And those in our stakeholder group were in these age groups, and so they were outspoken that they should not be all lumped together. So what were the sexual health issues facing older adults? We generally framed the whole piece in terms of the WHO definition, which is about preventing, as you know, preventing adverse outcomes of sexual activity, STIs, HIV, and promoting consensual and satisfying sex. So clearly the reproductive function doesn't quite, the reproductive aspect doesn't quite feature quite so prominently, although it comes in terms of postmenopausal women. There's reproductive health issues there, but they identified the main sexual health issues as STIs, HIV, sexual function, and importantly, the impact of general health conditions. There was a great deal of discussion in the groups about general health, and its interaction with sexual health, and I'm going to say quite a bit about that. So in terms of STIs, STIs get a lot of airtime in terms of older adults, and they certainly have recently. I'm not sure it's entirely justified. They account for a small part of the STI burden. Over 65 is just 1 in 70 of the total. The prevalence has risen, but it's a very low base. It's mainly MSM who have generally much better intervention set up than for those with opposite sex partners mainly. And so I think that's probably, the emphasis there is probably because it's more comfortable to talk about. Living with HIV, infections have fallen, but people living with HIV are predominantly in older age groups. And so they're likely to be coping with comorbidities. And we'll say a little bit more about that too. Sexual function is more common. 1 in 10 men, 1 in 3 women report symptoms affecting their sexual experience. So by far the bulk of the discussion amongst the stakeholders was on general health. And if we look at the graphs below, you can see that in both men and women, sexual activity declines with age. You've got the blue women and the red men. The more prominent line at the top represents those with better health. The fainter line, those with poorer health, self-defined. And you'll see that there's a difference there in terms of the rate of decline and the absolute numbers too. This led to quite a bit of discussion. It was pointed out that pleasure is difficult to raise, but if it's integrated into other health conditions, there's going to be a reciprocal benefit. The entry point of an overall health check for other diseases is also going to be a useful entry point, and I'll go into those now. These are summarized on the points that were raised, are summarized very briefly on this slide. So what was recognized was that there was an important reciprocity, a two-way relationship between sexual health and general health, and that it could be exploited in terms of improving both. As I've mentioned, they mentioned an entry point, so older people are not so keen on going to specialised sexual and reproductive health services, so the GP and the specialist consultation may be the first point of contact and an important source of information and advice, and indeed questioning about sexual health. Raising the subject of sexual health, moving over to the right, they mentioned would be easier in a general health context, reducing sensitivity. The diagnostic potential we've already mentioned, erectile dysfunction may be the first sign of diabetes and cardiovascular disease. And if older people are stopping medication because of its impact on their sexual health, then discussing that and discussing other ways of having sex, apart from non-penetrative sex, which I must say, respondents in NATSAL universally in the older groups were not very familiar with, really. But if we can bring that to the fore, then that would presumably have an impact on improving their take-up of medication. Common risk factors, as mutual benefit for sexual and general health of lifestyle changes such as weight loss, smoking cessation, and exercise. And as I've already mentioned, the reciprocal links between depression and sexual function, for example, and HIV and comorbidities need to be treated together. So we discussed with stakeholders what the barriers were to addressing the sexual needs of older adults. And they generally pointed to the fact that older adults were generally invisible and silent in interventions. They mentioned the culturally negative representations of sexuality amongst older adults, their reluctance to seek help, communicational difficulties. Gemma's mentioned the fact that healthcare professionals think patients are going to raise issues, patients think the reverse, resource issues as ever, and fragmented services. There's not enough joined up action between general health services and sexual health. How to overcome them? I'll deal with each of these separately, but briefly. Integrating sexual health into general health, creating an enabling environment, collaboration between key agencies, and training they thought was extremely important. So what might an integrated approach look like, looking at the first of these? Firstly, sexual health currently does not feature in annual health checks, and there's absolutely no reason why it shouldn't. Extending the role of mental health services to include sexual health, particularly given the link between sexual function and depression, and one stakeholder. So we need greater access to sexual health rehabilitation integrated into all physical health and mental health settings where sexual dysfunctions are common. Signposting patients in primary and hospital settings to relevant resources and services, and establishing wraparound HIV services for older patients. I'll give you an example of that to address comorbidities. Big exclamation mark there, because everyone emphasised that all of this must be within existing budgets. If we want action, there's no point in asking for more money for it. Here's the example of the wraparound HIV service. We had Jules Wright in the stakeholder group, and she described an impressive intervention in Brighton, which treated multiple long-term conditions alongside HIV. And there was a general shift that she was working in coordination with a geriatrician to prevent ill health generally. And they also provided social care to those living with HIV. I'm going to give several examples of these. There are really good interventions out there which might be scaled up and rolled out depending on the outcomes of possible evaluations. But it does seem as if there's quite a lot of work going on. It's just not very well known. Secondly, creating an enabling environment. Demonstrate inclusivity by including images of older people in sexual health promotional materials. And one of the voice participants mentioned this. There needs to be more advertising. Posters have been taken down in GP surgeries and hospitals because of COVID. They need to show older people. Otherwise, it looks like just it's for younger people. Media entertainment, fusing public health messaging with fictional storylines. We've seen this in programs like EastEnders and several, I can't think of others, but where there's been a storyline that has really brought to the fore issues relating to, for example, HIV earlier on and menopause more recently. And if these were brought into programming, that would help increase visibility. Co-op celebrities as champions. And obviously we're thinking of Davina McCall here, who's done such great work on the menopause. Position age relevant health promotional materials in places frequented by older adults. Now, those in the stakeholder group were mentioning gardening centres. I'm not absolutely convinced that gardening centres would want sexual health materials there, but an imaginative thoughts given to other venues would be useful. And very important, include older adults in policy documents on sexual health and sexual health in policy documents on health and aging. That's just not happening. Even the WHO only included sexual health in their documents on older people in 2017. And the most recent sexual health action plan from the Department of Health very, very briefly mentioned older adults. Here's an example of creating an enabling environment. This is Sharon Hinchcliffe's age-friendly, sorry, not her, this is the next one, I'll deal with that one. Sharon Hinchcliffe at Sheffield has done some very good work educating and informing and raising awareness. It's really worth looking at. I'm putting all these references at the end so you can see them. Really excellent work. And in Manchester too, although I find it more difficult to find a recent reference to this, and I fear that it may have fallen foul of funding. It challenges stereotypes, debunks myths, encourages conversations, and they really involve older adults in all the development work. It's really worth looking at. Finally, collaboration, multi-sectoral, multidisciplinary approaches, linking clinical services, third sector and other agencies. And I have to say that all stakeholders emphasize the need for third sector involvement. It tends to defuse issues, it always has done. It means that the government agencies can be a little bit hands-off, arm's length. Partnerships between sexual health services and voluntary organisations, and training. There are many tools for training. Here are some. Another example of some very good work, which is funded by the European Regional Development Fund, and they collaborate with the EC. And there are very good materials online from London Metro's Shift, that's sexual health in the over 45s. So it's really looking around for, it's really worth looking around for materials that meet the requirements of those 4 principles in what we need to be doing about this. And please do contact us for any further details of those.
Thank you very much, Kaye. That was really interesting. Were there any more questions? So no questions at this moment, but please do keep posting them if you have any questions going through, and I'll hand over to Alex. Thank you.
Thanks, Nicola. Can you see that okay?
Yeah, that's working.
That's great, thanks. I thought I'd just start quickly with a review of some of the data from the UK Health Security Agency. This is from 2021, just to kind of look at where we're at the moment in terms of ageing and HIV in the UK. In 2021, only around 5% of all people tested in sexual health services were aged 50 and over. And this number is far less than pre-pandemic. And we often look at that comparison in terms of kind of exposure route or exposure risk. So comparing gay and bisexual men who have kind of recovered from that dip in testing compared to heterosexuals. When we look at it by age groups, we can see here that actually there's quite significant drops in terms of the people that were testing, numbers of people testing before COVID-19 and afterwards. And this particularly impacts women. And there's not a lot of kind of like evidence behind why this is. I think we can make some assumptions. Potentially older people may have felt they were more at risk of COVID, so reduce the amount of sex they were having or the amount of different people they were having sex with. Potentially it's just getting out of the habit, and also these services have changed so much now with accessing tests largely being driven by ordering online kits and that kind of thing. So I think there's some things for all of us to think about in terms of actually ensuring that older adults are still able to access HIV testing. In terms of new diagnoses, just under a quarter of newly diagnosed people aged 50 and over in 2021. And we're still seeing a large number of people who are over 50 diagnosed late, and in particular those who are over the age of 65. So 73% of those were diagnosed late in 2021. And we know this has serious health consequences, and especially for older people. We look at this chart from UKHSA, we can see here just how much higher the 1-year mortality rate is amongst adults over the age of 50 and over the age of 65 compared to the average total. So again, this is something that we need to think about when we're thinking about fewer people in this age group testing, but also many of them being diagnosed far later than what we would like to see. In terms of those living with HIV, we have a similar picture across all the nations within the UK, and the number of people who are over 50 now has grown quite significantly within a decade, from 25% in 2012 to just under half in 2021. So this is why, you know, discussions around ageing with HIV have existed for a long time. There's been a lot of research that goes back years and years, but we're really now at a point in the UK where I think there's a lot of appetite to look into this more, and we're thinking about this more because such a large proportion of people now fall into this age bracket. However, despite the numbers, a lot of their needs are unmet, and they're quite an underserved community or representation of the cohort of all people with HIV. Looking more specifically at populations in England, here you can just see a breakdown. And again, there are a few differences within different populations, but we can see largely across the board, it's still, you know, no matter which kind of like population or demographic within the overall HIV population, a significant number now are over 50, and still quite sizable numbers are age 65 and over as well. Moving on then to specifically what we're doing at Terrence Higgins Trust. I'm going to go through some of the work we've been doing over the past couple of years, and just like to thank my colleagues Ruth and Paul, who were largely leading on a lot of this before I joined the team at the end of last year. So the COVID-19 pandemic provided a lot of unexpected opportunities to accelerate how people can access our services. So in particular, being able to access them online, so wherever they were in the country, especially if they lived in a space where there wasn't a local HIV support service near or close to them. One of the success stories for us was our Before 96 group. This is a support group that is a kind of a peer-to-peer space for long-term diagnosed people it was originally set up as an in-person service in London, essentially for people who had been diagnosed before effective HIV treatment had become available, and a space for them to talk about their concerns, and also a space where they felt they didn't have to not talk about things in front of people who potentially, you know, were newly diagnosed and have a very different experience and story with regards to their HIV status. Offering that online, we increased their membership significantly. Many more women now access that support group than when it was in person. I think our oldest member accessing the group is 82, and as I said, people come to that group from across the UK, and we even have a couple of people who used to live in the UK and now live overseas who are also able to access that space because of it being a virtual one. Our previous ageing research and also the Positive Voices 2017 survey were published prior to the pandemic. So Terrence Higgins Trust wanted to understand how needs had changed and what was different now for the ageing cohort and what their needs were. So utilising co-production principles and involving people who were living with HIV over 50, we started embarking on a review of what we needed to see our services delivering, how we needed to respond. A variety of different ways we used to do this. So we had an online survey. There were discussion groups, and these were, we had a couple of general ones where anyone could turn up, and then some more specific population-based demographic groups, including people who are living longer term with HIV. We also conducted one-to-one telephone interviews with people who weren't available to access an in-person or Zoom meeting. We also held more specific events with Africa Advocacy Foundation, who do a lot to support Black migrant people, and also McFarlane beneficiaries. And this is a group of people who are affected by the contaminated blood scandal. The data and findings were tested and shared with internal and external stakeholders, including people with HIV, and as well as being shared internally, were also presented to the people that had been involved from the community throughout the process. Overall, there were many different themes that came out of this review, but the three that were more prominent across all different groups and all different demographics were emotional and mental well-being, physical health, and social connectedness. And the only other topic, if you like, that falls outside of these, which was also one that came up a lot, was anxieties and fears around accessing adult social care services in the future. So we took a look at these in a bit more detail. And when it came to emotional well-being, there was high numbers of unmet need in a variety of different spaces. So almost half of respondents having slight, moderate or significant negative impact on their emotional well-being. Over half saying that HIV had a negative impact on their romantic and sexual relationships. Significant numbers also having negative impact on other relationships, so with family, friends, work colleagues. Many of them reporting experiencing depression and anxiety, and actually depression was the most popular comorbidity presented when people were asked to list what else they were experiencing, what other conditions they'd been diagnosed with. Many reported experiencing self-stigma, and just over a quarter discrimination from other people. In relation to physical health, just over a quarter had negative feelings towards their current physical health, and that was higher in people with long-term diagnosed HIV. Many were, would like to be more active but weren't sure how to go about it. And over 2/3 reported living with another condition. Only 28% of the respondents felt they were well informed about living well physically as they grow older with HIV. In terms of social connectedness, over half of respondents reported loneliness or isolation, and over half were living alone. Many of them would like more connection from different social groups and different clubs. The highest demand for social connection, again, was in those living with long-term diagnosed HIV. At this point in time, many people were still accessing online events, whether or not HIV related. And during this period, 80% of them were still planning to continue to access those in the future. But a significant number, over 2/3, were looking forward to seeing the return of in-person events. We came up with a number of internal recommendations of how to progress the work forward, but the sort of overarching ones that we were looking at was ensuring that all of our existing services were both accessible and marketed to those who are growing older, as well as anyone else living with HIV, to ensure we're providing specific services for those who are over the age of 50, and also providing specific services for people who are living long-term with HIV. We resumed our in-person activities in May 2022, began to sort funding to develop future pilots, which I'll explain now, and also recruited to the role that I'm in now. So we're continuing our commitment of Before 96 being delivered as a hybrid offer. So most people still choose to join that group online, but people are also able to join us in London at our office near Caledonia Road. But we're currently reviewing our 50+ social activities in London after doing a whole calendar year's worth of events and activities to work out what worked well and what didn't. We're ensuring that existing Living Well, our HIV support services, are inclusive and welcoming of people with HIV, and we're exploring how we can develop future partnerships. Everything we're doing now, we're taking a co-production approach and involving existing and potential people who are accessing our services in the decision making and how we design and deliver any future services. This year we've been developing some new pilot programs to tackle some of the issues that came out of the review, and in particular looking at improving physical health for people with who are growing older with HIV, and also kind of confidence around engaging in romantic and sexual relationships. The funding that we've secured is also helping to develop a self-directed e-learning training package for the social care workforce. And this is building on a previous THT training programme, which was the Can't Pass It On for healthcare professionals. Between March and May this year, we had 9 different workshops, which involved 13 different people who were living with HIV, who were 50 and over. This was a mix of long-term diagnosed and those who've been living with HIV more recently. And we've utilised those workshops to design the services which we're launching from this month. And we've also just undergone the recruitment of peer co-facilitators to ensure that these groups are being led by people within the cohort that they're designed to serve. Our main learnings from the co-production workshops that I'm able to share at the moment was a lot of anxiety about the future. So not necessarily problems that people are experiencing already, but the fear that they may do in future, and in particular around accessing adult social care, worrying about the loss of independence, worrying about HIV stigma, with some of the cohort also worrying about their sexual orientation, you know, openly living as gay men, for example, and worrying whether they'll be able to continue doing that, or if they have to think about how they might talk about the relationships they're having. A lack of confidence in primary care and other non-HIV specialist clinicians to be able to manage HIV with other conditions. And much of this is centred on previous experiences that may have not been you know, good for the people that were involved, but they might have happened some time ago, but they're still what people remember. They, you know, rather than thinking about the times where actually everything went okay, they tend to focus on experiences in their past where things were mismanaged, and also a lot of being passed around from different people, or when HIV is brought up as a topic, the non-HIV specialists getting concerned and trying to refer people back to their HIV clinicians. We also spoke a lot around language, which I think those of us who are working in the HIV sector and clinicians take for granted. You know, just simple like terms that we might feel are simple, like comorbidities, polypharmacy, were not understood at all when we were initially engaging with the people. So we've really having to think about consciously talking about things in lay simple terms with the groups. Acceptance around virtual and online services is dependent on the type of activity. Many of them sometimes just pure out of ease of just being able to turn on an iPad or a laptop or their phone and join in a support group that's online was, you know, actually easier for many of them. There's a lot of fatigue and around any kind of like instructional video content. So people don't particularly want to get involved in an activity online as such, but they would like to speak to other people and discuss things with them in that way. Throughout the co-production process as well, it was really clear that there was more complex unmet needs identified for women aging with HIV. So we are actively seeking further funding so we can explore those in more detail with women who are aging with HIV. I just wanted to end on experiences from Black and migrant communities. We've supported Africa Advocacy Foundation to produce a series of workshops which focused on some specific needs from the people that they support. This initially started with our user involvement team running their own kind of co-production workshops with some of their service users last year, and some of the needs were the same as what we would find with other populations living with HIV. So just general information about growing older with HIV and understanding what health checks are needed and routine tests and that kind of thing. There were some more specific areas and topics that the service users wanted to know more information about. So myself and Judy at AAF worked together to find different experts to come and speak to the group. In particular, there were things around arranging funeral plans, thinking about repatriation if someone wants to be buried in the country of their birth or where their children live now. And there were some really interesting things that we discovered with the groups around this. For example, it might actually, in a lot of cases, be cheaper for someone to be returned to their country of birth than actually have a funeral arranged in the UK. There's also topics which we see across many other areas around wanting to understand financial products such as life insurance, and then the same issues and anxieties around social care, but also with more specific needs that I was sort of like completely ignorant to personally. I take for granted like having thinking about the future, and if I had to access adult social care and live in a residential home, I'd never think about access to a barber, for example. But for some of the Black women, that has part of their identity, and it makes them feel good. It's part of ensuring that they can live well. And so having to worry about whether they'd still be able to access stylists who knew how to manage their hair was important to them, and something that they're thinking about. So there's definitely different things that we need to think about when we're looking at the different populations who are aging with HIV. And myself and Julie are continuing to work together to address some of these needs as well. In terms of accessing our support services at THT, the easiest way to contact us is through the website or via email. So if you want to ask any questions, it's tht.org.uk/livingwell or livingwell@tht.org.uk. Thanks.
Brilliant, thank you very much, Alex. We've had a few questions come in. So the first one from Emily, she says, do you know what policies in care homes are around supporting residents with their sexual health and education around STIs? And do you feel that care homes would be supportive with sexual health services providing STI HIV testing and providing education? And she's just trying to think about what outreach work she can do to try and help.
Yeah, I think in general what I found in just a short I've been in this role now for 7 months, in a short space of time, is that this often isn't on the radar of residential care homes at all. And what we find is that largely what's happening is when they do engage, it's reactively. So it's because a resident is registering with them and they've shared their HIV status, for example, and then suddenly they don't know what to do, and they the workforce there kind of approach an organisation like THT to ask for training on what they need to do. It's often fear-based rather than thinking about how to support the individual. It's often about them worrying that they could get HIV themselves and those complexities, which has been useful for us in terms of how we're developing the training package, in terms of how we get their attention, how we can put their fears and anxieties to a side. I think in terms of wider sexual health, I think it goes back to the kind of, what Gemma and Kaye were talking about in terms of older people and their sexuality, and the fact that they're still, sexually active is just something that most people aren't considering. I definitely think that there's more to do in this space though, and I would just advise just to reach out if you're in a local clinic and you know of local care providers, to approach them and see what you can do, see what you want to offer them, rather than waiting for them to react to someone approach them because they live with HIV or start to worry about STIs, that kind of thing.
Definitely. And there's another question from John who says, do you think the THT approach would be workable and transferable outside of London? And if so, how and what might work best?
Yeah, I think it's difficult. I think London has a wealth of expertise. There's lots of different services people can access. One charity one day, go to another support service the next, that kind of thing. It's definitely harder in spaces where there isn't anything. One of the things that we're looking to do with our kind of national approach, and where we're offering things virtually, like this kind of setup, is to ensure that we are marketing that to people who live in spaces where they don't have local support. If anyone's working in a support service outside of London and wants to talk about aging work, happy to have conversations about how we might work together, share information, that kind of thing, and support each other to support your local community who might be aging with HIV as well.
Okay, yeah, he's just said yes, please. So I think people are keen to have those conversations. And then there's also a reflection here. So somebody has said, I'm both a practitioner and an older person, and as a woman, my contact with sexual health services is naturally much reduced as I no longer need contraception. I'm aware as an older woman that cervical screening is still invited, and I wonder whether older women don't attend as they did when they were younger. This seems like a great opportunity or entry point for raising sexual health and response. And I think that builds on a lot of what's been talked about today. I think the clear outcome of all the presentations is that we need an integrated approach to discuss sexual health within physical health and mental health as well, not only for supporting people living with HIV, but generally around access to sexual health services and prevention, and hugely important as well, sexual pleasure. So I don't know if anyone wants to add a comment on about that.
I think, yeah, I agree. And what I would say is that where we talk about integrated services, they're often not as integrated. They might be on paper, but not necessarily in practice. And I think we're already recognising that potentially people who, for example, turn up to a contraceptive service aren't always necessarily offered a full STI screen or an HIV test when, you know, we'd like to see that happening. And I think it's the same if we're going to think about other areas like screening. You know, let's make sure that we don't, if we're starting something in that space, you know, let's think about that from the beginning rather than seeing the same thing repeat itself. And, you know, it's difficult. And I think sometimes it's training. Sometimes people feel uncomfortable if they're not used to offering certain tests, especially if individuals, you know, portray kind of like a stereotypical characteristic of what people presume HIV looks like, for example, and that kind of thing. But I think the way around that is universally offering these things and seeing what the uptake is like. Making sure that option is available to people. If someone is physically there with you, then it's the best time to offer them a test and a screen for STIs. Absolutely.
Were there any other final reflections? Kaye, would you like to add anything?
Yeah, I think one thing I didn't mention was a little warning from the stakeholders. They were very, very keen that older people should be present in discussions about sexual health. What they warned against was the possibility that by recognising that older people should be sexually active and sexually satisfied, that we shouldn't translate that recognition into a mandate, that we shouldn't make it mandatory, because there were many older people, particularly older women, who don't have partners or who are quite happy to be, for our research, quite happy not to be sexual. So I think it's a balance, really, that we don't go overboard and suggest that this is like a five a day sort of message, and that it's mandatory to have sex to be healthy, because there are many other ways of being healthy.
Yeah, that's a very good point, absolutely. And I think that's something important for women who necessarily that pressure to be sexual is something that they would have felt their whole lives. So definitely a good point. Gemma, did you have any final thoughts? I know you have to rush off.
No, I was going to mention what Kaye just mentioned, but I'll leave it there. My connectivity is really problematic. I'm sorry if you can't hear me properly.
Oh, no, we can hear you. There was just one last comment which said, I think women's hubs could really capture these vulnerabilities once they are fully functional in all areas for women, I think, but not sure whether we have anything for men. Whether there's anything around men's health hubs. Not sure, I think it...
No, we don't have men's hubs.
Great, so we finished bang on 1 o'clock, so I don't think there's any more questions coming in, but that was a really insightful, important discussion, and I think there was lots of important points raised, and I think it's good that there's clearly an appetite to start talking about this issue and to start doing something. We've had a great attendance today, so yeah, some promising outcomes, I think. So thank you very much for your time.